Good morning, everyone, and thank you for coming along this morning to the Small Business Innovation Research Program Information Exchange Day. I'm Christine Baraldo, and sorry, I have to stay close to the mic. I'm Christine Baraldo, and I'm the manager of the SBIR program, which this challenge is being run under. So firstly, I'd like to acknowledge the traditional custodians of the land we have gathered on today. I pay my respects to the elders past, present and emerging, for they hold the memories, the traditions, the culture and hopes of the Aboriginal and Torres Strait Islander peoples. Before we get into the presentation today, obviously I've got to go through a few housekeeping items. Bathrooms. Bathrooms are located, as you would have come out of the lift, past the lifts on the left there. And of course, importantly, in the case of emergency, the exits are located behind this event space. I'll do a quick introduction to the Advance Queensland initiative because the SBIR program sits under Advance Queensland. So Advance Queensland has 5 key priority areas, and under Advance Queensland, there's a range of initiatives aimed at transforming Queensland into a knowledge-based economy. Within that, so far, under Advance Queensland, there's been some great achievements. There's been 2,600 innovators that developed 11,000 jobs. 174 million has been leveraged, and we now have the second highest number of startups in Australia. So, Inspire. So Inspire, and the program's under Inspire, is about encouraging and inspiring Queenslanders to engage in science and technology and then become entrepreneurs and take their ideas to the world. So the programs that are under there are things like the Chief Entrepreneur, which is at the moment Steve Baxter, and he's located here at the precinct. And we also have Myriad and Founders Fellowships. The next one is Discover. And that's discovering new solutions to improve the everyday lives of Queenslanders. So it's really about research. So that's the PhD scholarships, the STEM skills, research fellowships, and of course the Aboriginal and Torres Strait Islander PhD scholarships. Moving on to Connect, and Connect is connecting Queensland to world-leading local and international innovators. So of course one of the key initiatives here is the precinct, and this is the space we're all in today. So this precinct has a number of startups, entrepreneurs working here, and it's a collaborative space that allows them to connect. It's a really key initiative of Advance Queensland. Under here we also have Hot Desk and the MIT Boot Camp. Invest, and we're investing in Queensland innovation through programs that encourage seed funding and venture capital. So we have the Ignite Ideas Fund, which is a really successful program that allows recipients to gain funding for their products to take them further to the world. There's also the BioFutures commercialisation program, Data 61, and the Regional Angel Investors program. And then lastly is Grow. And under this initiative, it's about growing the competitiveness of businesses and industry. And this is the program or the initiative area that the Small Business Innovation Research Program sits under. So I'll move on to that because this is the program that this challenge has been released under. And under this program sets out the process for applying for this challenge. So, the SBIR program, what is it? It provides funding to allow innovators to, I've had a cold. So it provides funding to allow innovators to solve complex Queensland government challenges. The program is based on two well-known international programs, the UK version and the US version. Both of those programs have been highly successful, and they run a number of challenges out through their program and have a number of success stories. So the funding is provided to innovators to solve their complex challenges. The challenge that we're looking at here today is the optimising medication use in the emergency department. So the funding, it allows innovators to develop and test their ideas, which can then be procured by the Queensland Government. So in the funding, it's provided in 2 stages. The first stage is there's a share in up to $250,000 to undertake feasibility testing. In the second stage, there's a share in up to $500,000 to undertake the proof of concept testing. The first stage runs for about 6 months, and the second stage runs for 12 months. So under the SBIR program, it is a long program. It runs for over 18 months if you conclude all of this application process. So at the beginning, on the 27th of March, applications were opened. On the 18th of April, today, we're here at the Information Exchange Day, and that provides you with an opportunity to learn more about the challenge, to ask the challenge owner questions, and to get a greater understanding of the challenge ready for putting in an application. On the 29th of May is when applications close. And then in mid to late June, there will be a solution presentation day. So after applications close, there will be an assessment of the applications, and those that have been shortlisted will be invited to come in and present at the solution presentation day, or in other words, pitch your idea. And then in June, July, successful applicants will be notified and will move into the feasibility stage. So that will run for about 6 months, and then of course after that, those applicants that have proven feasibility of their product would be then invited to go on to the proof of concept stage. This is a really important aspect of the SBIR program. Under SBIR, the government doesn't own the IP, the innovator does. So whoever creates the IP, the innovator that comes up with the IP to their solution, they own it. And that's really important because that allows the innovators to go on and identify other markets. So at the end of the process, you'll have a product that will be purchased by the challenge owner, but also you have a product that you can take to other markets if you so choose. Another really important part of the SBIR program is we do encourage collaboration. Often the challenges that are released through SBIR are quite complex, and they are across a number of, I suppose, disciplines. And so what we have on our website is a space dedicated to act as a networking catalyst. So it's voluntary, so you can go onto the webpage where the information about this challenge is released, and you can enter your details to go up onto the site for collaboration. Also, after today, there is a networking opportunity, so if there are any other innovators, businesses in the room that you are interested in, you can network with them to identify a solution and work together. And also, for those that have opted in to, when they reply to this event, your attendee list, or the attendee list, will be distributed to all. Importantly, of course, applications close on the 29th of May. They can be submitted, well actually they are submitted online. So if you are interested in applying, I'd encourage you to go online fairly soon just to become familiar with the application process so you don't leave it to the last minute. And of course, after applications are submitted, eligible applications are all going to be assessed by the evaluation panel. The evaluation panel is formed by the challenge owner, which in this case is Metropolitan North Hospital and Health Services. Yes, so as the challenge owner, they have the understanding of the problem they're trying to solve, and they will do the evaluation of the applicants. And I'm going to now hand over to Professor Louise Cullen, who will go through the details of this challenge. And after Louise has spoken, there is the opportunity for you to ask questions. Thank you.
Thank you very much for that. My goodness, I'm a fish out of water here. I'll show you where I normally work. This is way beyond my comfort zone, so be gentle with me. There's me again. To give you a little bit of background and to understand the challenge, I need to take you into the emergency department and show you some of the problems that we actually have. And to give this context, according to the Australian Institute of Health and Welfare data, we see over 7.7 million ED presentations per year in Australia. And this is what we know for all the reporting hospitals. We know that there's a growth of about 3 to 4% every year in terms of presentations. With this current rate of growth, our healthcare services, as you can imagine, are under incredible pressure. And it's not sustainable unless we begin to find ways to deliver care more effectively. This makes up part of the reason why we need this sort of challenge. So this is my home, not literally, but sort of. The emergency environment is a complex environment. It's time pressured, often it's high stress, but actually for people that live it and breathe it all the time, we actually enjoy it, and so we don't find it terribly stressful. It's made up of shift workers who work, of course, 24/7. There is no such thing if we're talking about trying to improve things or change things, about calling a meeting and having everybody in one place at one time to actually hear where we're going to actually alter things. Our department is made up of a multidisciplinary team. We have prescribers, which are predominantly doctors, but we also have nurse practitioners, and we have physiotherapists who prescribe. But of course, we've also got nursing staff, social workers, and other community support people as well. There's a huge variety of experience within these people. We have a core group of people who've decided to specialise in emergency medicine, and they are a group that are a constant there. But every single first-year doctor in Queensland, in Australia, must come and do emergency as part of their rotation. So we see at the Royal Brisbane, for example, 90 different first-year doctors or interns every year. And we have 120 of other staff that are coming through, as well as junior doctors that transition through. We teach, therefore, the people that are not just going to be emergency physicians down the track, but the people that then go into general practice, neurosurgery, cardiology, you name it, we see them all. So we've got a sphere of influence of these junior doctors at an early stage in their career that we might be able to impact some changes to. Within the emergency department, it's an incredibly what we call a decision-dense place. It's probably in medicine the place where there is the most density of decision-making. It's been estimated that we see there's possibly up to 10,000 different diagnoses in people that come to us. But the vast majority of people come to us with things like chest pain or abdominal pain, breathlessness, mental health issues and drug-related things, as well as trauma and minor injuries. We need to make decisions within a succinct amount of time. And we don't have the luxury to sit down, read through charts, read through journals, look at other sources of information often to determine the best way for care or options for care. This high amount of cognitive load, as you can imagine, means that we're processing an awful lot of data. And on top of this, we have things like surge phenomena, times where things are a lot more busy because of increased patient volume. We also have times where we've got to think about things like physician fatigue and sleep cycle disturbances as well, that often impede in our learning and understanding. We get unpredictable situations like sick leave or hospital disasters as well, and this is sort of the environment that we work in, but it itself limits our ability to take on and apply new knowledge and information in a reasonable way. So the way we tend to do things is the way that we've always done things. Medicine, believe it or not, is a lot like apprenticeship. We go to medical school, but after that we learn a lot on the job. And things that we do, particularly with relation to prescribing, is just the way we do things. I tend to give one particular drug most often for people that come to me with nausea and vomiting. I've got a list of about 5 that I could use. 5 that I could choose from, but I use one just because I'm most familiar with it. And if you ask a lot of the practitioners, we do what we do because we know it frequently, we know how to use it, we don't need to look things up. I know it's easy, and so I fall into the pattern, like many others, of doing things just because of habit. One of the key things in terms of medicine, probably the most prevalent or the most common intervention that we do for patients is prescribe medications, whether it be to prevent, treat or manage illness. But there's a lot of concern about increasing use of medications and can we do things better. There's potential overprescribing. There's been a lot of interest at the moment in overprescribing of antibiotics, for example, and opiates. And we've been trying within our own department to try and constrain some of that prescribing appropriately. We've also got to look in terms of, it's hard sometimes to reduce what people see as inappropriate. There's a big push in health at the moment with the Choosing Wisely national campaigns and others to look at value-based healthcare. Where are we actually investing the money the best and providing the best care? So value is not just about our clinical safety and clinical efficacy, but it's also about the costs of the treatment that we are providing to people. Now, you would find that at the moment, most clinicians are not engaged in the economics of healthcare whatsoever. New information that is received to us as clinicians about clinical practice is all about clinical efficacy, how good it is, how well it works, or about safety. We're not presented anything in terms of reference to costs of procedures or medications at all. And we're not trained at all in medical school about the health economics. But with the increasing pressure on health budgets, we're not stupid. We know that if we don't get become part of the solution in terms of cost containment and appropriate use of our resources, we may end up with a system like the NHS where we're told you can't have access to that drug, you can't have access to that procedure, or the managed care sort of phenomenon, which we really don't want to go there. So we believe that sort of engaging clinicians on the front line, the ones who are actually spending the dollars inadvertently without even knowing how much the dollars are that they're spending, is essential for part of the solution. And so how do we change them? That's probably the biggest problem from a clinician's point of view that doesn't have any understanding and knowledge about that. And from a clinician, when we think about doing things differently and creating change in an efficient and also sustainable way, it feels to us like we might have to climb Mount Everest. What we do know is that from the time it takes for a new discovery, for example, of a drug or new medical interventions to actually impact on clinical care, it's of the order of 10 to 17 years. And that's a lot of wasted opportunity, as we see, for innovation to be actually incorporated. So there's a couple of key issues to think about when you think about sort of the EU space and where we're in. This is what we're faced with a lot of the time. We're just too busy to take on something new, to think differently, to change the way that we're doing it. As I've said to you, we have very little time to sit down and actually think about things. The vast majority of prescribers do not have any what we call non-clinical or clinical support time or offline time to actually sit and read lots of journals and things. That's what we do in our own time, believe it or not. All of the time is committed to one-on-one patient care and patient contact. We also have absolutely no line of sight of cost. I could not tell you, if I had looked in our medication cupboards, what the cost of the different drugs were. We don't see that at all in our training. We can't see the value of what we do, and as I said, we tend to do things just because we learnt it when we were very junior, our bosses told us to do a certain way, and that's just continued to be the way through. And as I said, we can't see the options therefore. We can't see also the pressure points. So for some things, when I talk about options, there are alternate drugs options that might work equally well, but we don't know them, and we don't know if there's one that's more expensive than others. Often also there's differences in the route of administration. So we use a lot of intravenous drugs, put it through a drip into people's veins rather than tablets in the ED. And as you can imagine, there's a whole lot of cost that's associated in terms of staffing costs and time costs. We are running flat, and to ask our nursing staff to do something, to give a tablet is often a lot more efficient and cost and valuable than using the IV, but we don't necessarily see it as clinicians, so we just order the IV because that's what we've always done. We need some information, but not too much, as you can imagine. There's problems where we've got alternate medicines that we can choose. There's problems when we've got new medications from new research that we might need to adopt or change our prescribing practices. Equally important though, we can't have it where if you have condition X, you only get access to drug Y. And it doesn't work for a number of reasons. Often there's things like patient allergies, there's comorbidities, there's drug interactions from what they're on. We can't have a forcing function whereby you say, there's only one option. We need to somehow nudge people though. If they can make the choice and it's appropriate, we need to nudge people in the right direction to get hopefully better value out of our important dollars. And data, I think, is fundamentally important. And as clinicians, we hear that we are drowning in data, but we don't see it. We don't see it whatsoever. And the only reason I sort of see some of this now is I'm a bit more senior and I've been able to look over, what are the top 20 drugs that have been prescribed in our department over the last 12 months. The people at the coalface have no concept of that whatsoever. Because we can't see relevant data at the coalface, we really can't see opportunities for change. If change occurs, we can't see what impact we've actually had. And therefore it's not reinforced that we're doing the right thing, and often you just slip back to doing what you did because that was a bit hard and I'll just go back to what I was doing. The data though of course needs to be locally relevant, and you'll find the pressure points at the Royal Brisbane in our ED will be different to different emergency departments around Australia. And as I said, we need to make sure that we can make this a locally relevant thing to tackle the key priorities in individual emergency departments rather than being a generic thing. Equally, we know a few things that don't work. Targeting individuals and saying you prescribe the wrong thing. Our responses as clinicians is often counterproductive if we do that, if we're put under the pressure. And yet we know from some of the initiatives, you can see a badge on here, this speed signal. We've done initiatives about trying to reduce the number of cannulations, the needles put into people in the ED by running a campaign like this. And by getting everybody on board for the greater good rather than going and targeting individuals, we've had success in changing the culture of things like putting in cannulas in the ED. But people needed to see what the greater good was and get that feel back. In doctors and other prescribers, you're up against, if you target people and push people that away, you're going to get pushed back about them losing their autonomy about decision making. And that's strong. As I said, we don't want to end up with something that is like the NHS, for example. And so we've seen things that have worked effectively has been the use of collated data, department level, high level data for department initiatives. And so things like the ability to obtain comparative historical data and map trends and things like that may give us some insights to how we're going, show us the effectiveness of change and provide proximate feedback to clinicians about it. Don't forget you're dealing with a whole bunch of people that are type A personalities and we like to succeed, and if you set us a challenge that we want us to be there, we do hard to try and achieve it, that's for sure. There's got to be significant flexibility in the solution to deal with the wide variety of treatments that can be provided and pressure points that individual departments might find. As I said, we want to target key priorities. When you look at the top 20, I look at a few drugs on our top 20 list and completely scratch my head as to why they're even in our top 40 or 50 list. We don't actually understand why. We don't have the time to go around and audit this individually, but we think we might be able to change prescribing practices. It's also going to be scalable and flexible as well. The other thing that is important is that we don't understand as clinicians is how do we effectively get our messages out to make people change. We're in a busy environment, we've got very short attention spans, that's why we're emergency physicians. We've got competing issues for our attention all of the time. So the messaging and communication is something we've got to also realise that we have got the very junior, IT savvy people, as well as the more senior group or the more stable group who are less IT savvy, should I say. We've also got to be careful about the scrutiny of the data and what is available, and in particular, the confidentiality of patient-level data, which is ideally avoiding all sort of anything that can identify down to individual patients is absolutely fundamental, maybe through something like collated data. And this is one of the things that we see as the future solution. This is a new system called Pyxis, which allows us to very accurately record stock usage. And you can do it sort of time by time, but if you do collated data over days or weeks or things like that, it can be audited and interrogated at frequent time intervals to tell us what we're actually using. And we could use that to see trends and things. Now, prior to this, and this is only very recent in terms of our use of it, if we tried to change anything, we actually literally had to rely on someone manually going through and individually counting stock and then writing on a spreadsheet and reporting it back to somebody to actually know what was going on. And so there were delays in terms of time for us to ever see something. We lost the impact of any change initiatives that we had tried to implement. Now, there are a whole lot of IT systems within Queensland Health, and I am not going to tell you that I'm the person to ask. I'm very fortunate to have Dwayne Nightingale here with me. He is the Metro North Manager of Enterprise Architecture, and he is the one that will have the different, understandings about some of the different systems that are involved. But equally important, we will be moving down the track towards FirstNet and other solutions in terms of e-health. So just to summarise, for this challenge, we actually know that there is a better way forward. There is a smarter way for us to use valuable healthcare dollars to continue to provide excellent care to the community, both for now but also for the future. We just need your help in actually getting it there, and we hope that you might be able to find a way to get us there. The good bit is that at the end of this is only one thing. We've decided we're going to focus on medication use at the moment. But there's a whole lot of other opportunities. For example, in X-ray ordering, radiology, CAT scan ordering, blood test ordering. If you can find a way to give us that sort of information at the coalface, there's a whole lot of opportunities we see where we believe there is some wastage or redundancy or practices that may be outdated just because it used to be done that way, we keep doing it the same way, where there's other opportunities to improve the delivery of healthcare in terms of looking at the value for it. So we're hoping this will be relevant everywhere, and equally it will be very relevant not only in public emergency departments, but even more so in private, where of course cost containment is absolutely essential. So look, thank you for your time. This stuff scares me because, as I said, it's way out of there from what I normally do. But I think we've now got a panel where we'll be able to sit down and hopefully answer any questions you might have. So I'll introduce the fantastic panel that we've got here at the moment. So Mark Rawwood is currently the Director of Greenslopes Hospital, but he's also a part-time emergency department, Greenslopes Emergency Department, not the hospital. But he's also a part-time specialist at the Royal Brisbane Hospital and is one of our medicos that's got some IT savvy. There's very few of us around. Beside him, we have Elizabeth Doran. Liz is our emergency pharmacist, so she works on the floor with us as clinicians and helps guide us in terms of our prescribing. Dwayne Nightingale is beside there. As I said, he's the manager for the enterprise, IT solutions, and the director of the Royal Brisbane, Metro North or just Royal Brisbane? Royal Brisbane Pharmacy Department is Ian Coombs, Professor Ian Coombs on the end. So we're happy to take any questions you might have about the challenge. At the back. We might read it.
When will the RBWH-ED implement the new IEMR, and do you think that will change some of the prescribing problems?
Currently, plan is within the next 2 years. Obviously, that depends on funding, so it's still up in the air, but we expect within the next 2 years. Yes.
I guess one of the things we perceived was that there are individual differences in prescribing in different departments that are real and relevant, and that some of the data that we'll get from Pyxis, from the system we use to dispense medications now, is granular and allows us to guide prescribing at a local level and connects what people are doing at a local level more than just a therapeutic guidelines type document that's been published Australia-wide, which is what currently people would probably try and refer to in prescribing. So there will be some differences, there'll be some commonality, but the granular data that we have is the most relevant thing we think that can change people's practice. We can look at our department and say, we're prescribing way too much azithromycin for pneumonia, for example. We're spending a bucket of money on that, which we just don't see where that's coming from. And we can give that feedback back to people in our department by having the data. Sarah.
There are a lot of medical students and junior doctors that do audits, medication audits for the ED. Will you allow the problem solvers to have access to that audit data and other data?
I guess we're looking at trying to get a system which allows us to find that data and give it back to the people who prescribe. And so yes, this is the short version. If we can find a way of systematising that and making it useful, that would work fine.
And we hope that gone will be the days of medical students trolling through charts to do audits of medication. We've got to go away from that. That is the most laborious, time-consuming waste of public taxpayers' money to really affect change. With systems like Pyxis, we can get the information that will link us back to the individual patients. If we did need to get more than just the actual volume of medications prescribed, it leads us one-on-one to then go and target those cases, so we can do some interrogation of that. But you know, we hope that the system would allow us to stop some of those practices, which is our current way of seeing if we've done a better job than we did last month. The lady in blue, sorry.
So is Pyxis being implemented in a number of EDs, and is it being implemented anywhere else within the hospitals across the service?
So as part of the electronic medicine management program for Metro North, we started with the emergency departments for implementation of Pyxis, quite contrary to a lot of other hospitals who either leave it because it's too difficult or chaotic. So it goes across all our emergency departments by the end of this year, and then it'll be going into other wards as well.
It's also used at Logan Hospital.
So yeah, I mean, with regards across the state, people are probably aware it's been in places like Townsville for about 15 years. It's been in Logan for in their emergency for about 4 or 5 years. It's in a lot of other states, other hospitals, Rockhampton, Mackay, and other places are also looking at it. It's not a sort of rocket science thing. It's just part of our plan.
You've spoken a lot about getting information around audits, so historical information, and there's loads of that. You spoke about drowning in data. Real-time data and real-time access to that can make all the difference. In an emergency department, you spend probably 10 minutes and information is absorbed in 10-minute bites. It's a really fast-paced environment. What do you see as helping you to make those decisions in real time? Would you use a mobile device of some sort? Would you use a wearable? What do you see as being the optimal?
Because we're trying to influence our group of people, so in any one shift, I've got more than 30 prescribers per shift on the floor at that time. We want them to see the same sorts of information, we want them to see the same sorts of initiatives that are there. As I said, you know, we think for some medications that we use, we might be able to cut it by half. There's other things that we think, you know, from a high level, we think are being used appropriately. We want to be able to target those ones where we think we can make the greatest change, which means that it's got to be something that the community can then get behind. So it may be something that's up on a wall that's interactive, that people visually sees that. We are visual learners as well. You know, the things that capture our attention are things that change. Now the problem at the moment is that we've got posters there that's been stuck there for probably 18 months that need to be ripped down. People go initially, oh, what's that? That's interesting, I've read it, and then it just falls away as noise. So we've got to try and get away from all of the other visual noise to get something to people. Again, you know, in this tech-savvy group that are very much on their phones, that may be appropriate. You've got to convince the older generation people as well, and they have to have the sight of it. You do find that because there is a core group of people that are the permanents always there, that they influence the juniors. So when an intern comes and says, what do I give to this person? You know, they're looking to us for guidance. Now, we just do what we've always done, as you've heard, because we don't know any better. So you've got to try and help us change to help them change, and we're hoping they will take this knowledge and information on in their careers to help guide their practices down the path. So I don't know whether it's going to be an app or a phone or a thing on the wall, or it's got to be something visually engaging for us all as a community.
Can I just also explain a bit about the other kind of support and decision making that's available in the ED at the Royal Brisbane? So where we are quite different from most emergency departments in Australia is that we actually have a 14-hour-a-day clinical pharmacy service. So there are actually a core group of pharmacists on the floor who actually help educate all levels of staff with decision making. So actually I'd argue that if you've got to the point where you're going to the robot to get your drug out, that's probably a bit too late. It should be happening a bit earlier in the food chain and decision making process. So where possible, we actually support the doctors with making decisions based on cost effectiveness, clinical efficacy, safety, etc. And that's through all levels of staff, and there's quite a lot of very good education for all levels of staff in our department, but that's something where on an individual and group basis, that interaction actually supports that, and it's not just about getting drugs out of the cupboard, it's about making those drugs fit the patient appropriately. at that moment in time, just to clarify if anyone's interested.
Thank you. Just regarding Pixis, is it a shared central hub of data, and how can it be extracted and analysed to learn from it?
Take that one on notice, effectively. With regards to, I suppose, when you're saying a shared hub of data, are you talking about the state? Are you talking about multiple emergency departments?
A catalogue data. So is it a stream that's, say, we can extract to use machine learning on it to learn from it? Is information shared between emergency departments?
Is it shared between emergency departments? It can be.
Yeah.
So, I mean, it's in Redcliffe, it'll soon be in Prince Charles, it'll be in Caboolture. At the moment, we're sort of in the early days. We've only literally just put it in to see what data comes out, and we haven't got historical data in there to know what's going to come out. But ultimately, if it's data which is in the right language, we should be able to share it. It obviously has to be de-identified, and from a sensitivity point of view, whether it goes outside of Queensland Health, it's a donor benefit.
Morning, Charles Cornish from DoseMe. Just two questions. The first one is, when you talk about value-based care, are you looking outside of the ED or just specifically within the ED?
If we can start in the ED, it will go further. We've got to sort of bite off a chunk here and prove that the way of influencing and changing clinicians' behaviour works in this sort of environment, and then this can go anywhere. You know, if you're on a medical ward, for example, or a surgical ward, and you're finding that you know, people are feeling that there's too much prescribing of X, we'd hope that this modality would be able to be utilised in that same sort of thing. You know, as clinicians, we sort of look at the top down sometimes, the more senior ones, and sort of go, you know, why is this happening and why is this happening? But this sort of system, I would hope, would work at any ED, any ward, anywhere where you've got this ability. Behavioural change is something that we don't understand, and as I said, we're entrenched. You know, for new things to take 10 to 17 years to actually affect patient care is crazy. We just need the skills to be able to pull things more quickly. But I would have thought public, private, as I said, not just medications, but radiology, X-rays, and pathology ordering as well. We should be able to influence lots of different people for lots of different things, I would hope, ultimately.
Okay, and the second question is, are you more interested in dashboards and sort of more macro change management, or are you looking at clinical decision support, point of care? There's a lot of clinical decision support tools out there. The problem with that is that they're not locally specific. They are influenced by, you know, things like Australia-wide guidelines that therefore don't look at the pressure points. There's nothing that then from the top down can say, we don't have a problem with all of those drugs that you can access to. They actually have problems with these other things that are not there. The other thing is the labour that goes into a clinical decision support tool. It has to be continually updated with the new medical knowledge coming through and change and things like that. Now, I'm not saying that this sort of system wouldn't need the same thing, but it's incredibly hard to change some of those clinical decision support tools without having a doctor sitting with you, interrogating the literature, pulling it all in, you know, evaluating and putting it in at the same time. So there's reasons why we don't want to go down to a single sort of clinical decision support tool. We want to look at the macro level. So it's more at that level that we're trying to look at for a department-wide.
Hi, my name is Avnish Bhagwas from Leader Healthcare. So is this program only open to, say, IT and data works, or as Leader Healthcare actually deals with companies all over the world and look for the innovative devices? It could be happening in Canada, in UK, other parts of Europe or Asia, and these are, most of them are commercial products which we think can help Queensland or over here in Australia. So is this program open to those commercial?
Yeah, no, absolutely, and so it's really wide. We don't exactly know what the solution looks like, as I said. I think I've tried to explain the environment we work in and what sorts of things are the issues, but we don't know what the solution looks like, and that's where we're hoping that you might be able to come and say, you know, we scanned what we could see online, we tried to go through different things to see if there were solutions out there, we couldn't see anything, but you might know of things that can be integrated into this, I think it's fair to say. I'm just looking for the SBIR team, sorry, as well.
So how can we if you can explain the ideas how we can submit to this program.
Can I pass that to
29th of May, right?
Oh, okay. So yes, if you've got a pre-existing idea, that's no problem at all. The program's open to anyone, any organisation, any size, and it can be anywhere as well. It doesn't need to be Queensland-based, it can be nationally or internationally, depending on where the solution comes from. So if you've got an idea that you think is already feasible and can work, under the program, you don't need to go through the feasibility, the research development side. You could jump straight into proof of concept. Obviously, the panel will determine whether that's suitable or not, and then you can do some trialling or testing of your solution. So it is flexible to allow for that. Does that answer your question?
Yeah, thank you.
I note the funding is shared, which I respect that. Is there any guidelines as to how shared, just in terms of it's no good as submitting something that completely is outside the sharing of that amount?
Yeah, well, no, there are no guidelines as to the sharing of the funding. It depends on what your solution is, and then, of course, the other applicants and what their solutions are. So the panel will look at all of the applications that come through. There may be some that they will fully fund. They do have the flexibility to do that. There'll be some that they may only partially fund, depending on the number of the solutions that are provided, and then, of course, the costings in those solutions. So it is really difficult to answer until, the panel sees those solutions come through.
So this is a huge problem with lots of scope. Out of all the problems you've mentioned, prescribing, you want to change people's prescribing practice, you want a decision tool that is updatable. Like all of the problems that you've listed, what is the most important that we should achieve minimum out of everything for this?
I guess what we want to see is that we can influence, change and sustain that change, directing people towards value-based healthcare. Still too vague, got to be specific. I'm intentionally not specific because, and I guess that's probably the guidance that I've been given is that, way back when we first talked about this, which is nearly over 2 years ago, we locked into something that we thought might work. We're clinicians. We don't have the expertise in behavioural change. We don't have the expertise in communication and marketing. We don't have the IT technology. So our change that we drafted, when you look at it, you think, oh, that's a joke. We can provide guidance on what we think influences this particular weird population of people that call themselves emergency physicians and work in emergency departments. We sort of know a bit about that, but we don't necessarily know what it is. So we need a solution that's going to show us pressure points, give us guidance about alternatives, whether it be therapies, routes, gives us some view of the health economics of the care that we are providing and shows us if we've been able to change that and sustain that change. That's all. Yeah, information that is locally relevant and proximate to our care that we can utilise, yes.
Good morning. Thanks for sharing the challenge. I'm finding it really fascinating. I come from human services, so the health space is a bit new. I've just got a question about the format, leading on from the previous question. Do you have a maximum number of candidates that you see going through the feasibility stage?
No, actually, is a simple answer to that. It really depends on the applications that are received and how closely they're hitting the mark with the solution. So it really be up to the challenge owners who will do the assessment because it's their problem that they're trying to find a solution for. So I can give you some, I suppose, examples from other SBIR challenges that we've run in the past. We normally have anywhere between 2 to 3 applicants move through the feasibility stage. So they're the numbers that we're looking at. Again, this challenge, it could be different. We could have more that move through or we could have less. But ideally, it is at least to have 2 applicants move through. And that's because it's a competitive process, it's a procurement process, and that competitive tension is important for that as well.
Can I just give it, we thought maybe giving an example. So a patient comes in who's nauseous and vomiting. As I said, I've got 5 different choices of medications that I could use. I use one and maybe another one just because I always use that one. And there's a couple of contraindications for it, so I sometimes use the other one. But there's a whole lot of other things from there. As a clinician, I just do, as I said, what I want to do. But if my director and if the department says, look, the cost of this now is increased to this much. We're now spending X percentage of our budget on there, and really, that other drug works equally effectively, but is less expensive. I need to be able to see, and he decides that there's a campaign that we want to actually now try and shift people from that drug to that drug. I need, as a clinician on the floor, to go, oh, there's something that triggers my memory about this, and I've seen something about this, I can see this, I want to be part of this initiative. Our department said we want to save $600,000 over this 12 months for this particular drug, you know. So I know that I can, if I just change this one order, what we don't see as individuals is if I do one thing differently, that it ever contributes to the greater good. So as a clinician on the coalface, I then need to see, okay, well I might take option 3 now, because I can now actually see what that costs. I have no idea. I know that Liz has said she's got some idea about cost. No clinician on the floor would have any idea in a public health sector about the cost of the drugs that they are using, and yet sometimes there's a 10-fold difference between them. So I need something to influence my behaviour to choose drug 3 rather than drug 1 or drug 2. That gives a little bit of clarity.
Good morning. Sorry about the sunglasses, I'm sensitive to these bright LED screens. I wondered if we made a proposal for a feasibility study, how much access we would be able to get to staff working in the emergency department. Because that would be a core part of the way my company would approach.
So I think if you get through the feasibility stage, we will avail ourselves to work with you to get to the best bit. I don't think you can do this without the health knowledge, you know, and I think that that's the key thing. We don't have that smarts, but we can give you the top 20 drugs that we want to try and change, you know, and let's start small. Let's just talk about 1 or 2 and let's see if we can walk before we run. We can give you the bits and pieces. We're the ones that are across the new guidelines or the new research that's come out to say we should change X or Y or Z, and we can give you that. We happily work with you with that, absolutely.
And I'd imagine you mean also end users and access to them?
Yeah. That's what I mean is many different stakeholders, very different roles in the emergency department, local roles to interview and access several people. It's just a matter of how much time would you be able to make it available to talk to, because obviously everyone's, as you say, working all the time on a shift. You go home and most of the time and really be able to allocate particular people in particular roles for
Yes, okay.
So Sean Drummond, the CE for Metro North, is backing this. You know, we have got a big campaign about value-based care at the moment. We want this to work. We want to make it happen. So you've got our time. Yeah.
Thank you very much. I'm just wondering, with Pyxis in place, what information are you capturing? So say a resident's prescribing an antiemetic, what do they need to enter before the drug gets to the patient?
Fingerprint and a scan. I think it's important that the prescribing actually occurs on a physical paper drug chart, which the nurse then reads and then goes and gets it from the Pyxis. So realistically, nothing needs to be entered into Pyxis apart from this patient, I would like some of this drug, and I'll get it out. And that's it at the minute. And it's cross-referenced with allergies, etc.
Right. Yep. And indication, so that isn't captured electronically?
No, there's certain things that we can put in that are codes to say you are meant to be using it for just this indication. So a good example would be, do you want to use this medicine, if you are using this medicine as an antidote? Yes, you can have it. And if you say, oh no, I thought it was for something else, then it won't let you get it. But that's basically it.
Thank you.
Yeah, I mean, I think it is important for those people who aren't familiar with it. We're not talking about a complete electronic medicine record yet. We are talking about one component of the closed-loop electronic medicine system, which at the moment has an analogue paper national inpatient med chart order. So the PICSA system will log to the individual patient. It will then be able to track the actual drug, but not the specific dose. It'll only be the vial size or the tablet number taken out for that patient at that time. But via the other electronic systems, you'll be able to pull out who the people are who see the patients through other systems, such as EDIS, etc. But it's not we're not talking about a complete electronic medicine record at the moment, and we're doing quite a different approach to electronic medicines in Metro North to, for example, Metro South. So we're testing a different prescribing system, order entry system at the moment. So there's quite a different staged approach, a different amount of information. So PICSIS is a way of tracking once the prescribing decision is made. But I think the key point is actually utilising that information as usage to feed back to the way we believe we treat hospital community-acquired pneumonias, or how we treat VTE, how we treat chest pain, how we treat ankle sprains, to actually then look at what drugs are used at what time and what quantity, which, as Louise rightly said, at the moment we do an awful lot of labour-intensive retrospective auditing to look at drug usage through charts to pull out that data. So to be able to use that to feed back to actually influence behaviour linked to guidelines and decision support is more of that perspective. So it's important you know what kind of world you're looking at.
Just on that, on the pharmacy front, how effective have you found your intervention to be with talking to clinicians on the floor?
Close to 10%.
What was that?
Close to 100, I would say. 9 times out of 10, if we go to, there's two ways about it. Sometimes you'll pick up a chart and be like, that doesn't seem quite right, I'll go and investigate what's going on there. And you might say, I'm not sure about this dose of antibiotic you're giving, or choice of therapy. And you'll have a discussion, and you might make a suggestion to say this dose or different drug might be better. You'll have a proper clinical rationalisation, and usually, I would say close to 95 to 100% of the time, that will change the decision.
But the problem is penetration.
Where it's appropriate.
Yeah. As Mark said, the problem's penetration, and we are blessed at the Royal Brisbane to have this service. We're the only one that's got it though, at the moment, in terms of someone there. And equally, there's only one of Liz. We see 240, 250 patients a day. You can imagine that it's incredibly difficult to touch base with all of that at that sort of level of detail.
And just on that, are you taking in demographics of the patient with those drugs? So sort of a person from X background, that drug is different to prescribing that one with the effectiveness of that drug interaction for that individual?
So we take demographic data as the patients come to emergency and they are triaged through, that can be linked then because they're given their patient ID number. That patient ID number is linked on a different system back to identifying information, postcode, gender, all of those sorts of things there. But it's not in PICSIS itself, it's linked back through their patient identification number called their UR number.
And those systems don't currently talk to one another?
No.
You mentioned a couple of other systems like FarmNet. Is there information going to be available from those? Is the system needing to utilise that, timing of that?
I think you probably have access to the data that we use in terms of, there's iPharmacy, which is a dispensing software in the main department, which talks sort of to PICSIS, and then so you'd have that data plus the PICSIS data, which would give you an overall drug usage picture and number of units moved and high cost items, and things like drug charts and things.
Anytime you get down to patient level data, you've got huge problems. We're trying to find a solution that lifts up and out of that can look at collated information without patient level data. Because Queensland Health is such that no, it will not transcribe across different jurisdictions. There are so many problems with patient level data, it's not funny. Even on the inside, with audits and things needing to go through review processes to ensure that in terms of governance and ethics that we are doing it the right way. Patient level data is a nightmare, and I think if we're trying to get things down to patient levels from this solution, we're going to be in trouble. will be wrapped up in a whole lot of things that may not allow it to progress.
Louise, can I just probably clarify for people? So part of it, I said before, so Metro North has a staged approach to an electronic medicines management plan. And I think that, whilst the state has a sort of large big picture switch on one system, we're taking a very much evidence-based approach to that system. So we are trialling an electronic prescribing, order entry, administration recording system, which is actually MedChart, which is also mentioned in the system, across our medical floor in Caboolture and across our geriatric unit at the Royal Brisbane. The evidence of that system, in its usability, its impact, its safety and its efficiency, is to inform the decision which prescribing order entry system we go with. The approach to direct order entry into the IEMR is part of what we've all signed up to, and it's probably fair to say that Metro North, as we're just doing with pathology, is taking a best-of-breed approach rather than a one-size-fits-all. So in the future, Sue, yes, in a year, 2 years, 3 years, we will have an electronic prescribing order entry which will link to a patient, a condition, a prescriber, a time, a place, when the drug was given, and then the Pyxis will say, yes, that drug was administered. At the moment, we're sort of working backwards with a small piece of the pie of the entire medicine management circuit. So we are sort of trying to future-proof what information we've got, and the fact is we can now. So for example, another piece of work that Liz is looking at is the acute use of antipsychotic medicines. So we can actually look at top 3 drugs, what are used, how often, which patients, what was the primary complaint, what was the condition. So we can actually have a lot more detailed data than we have done when we've just done about a 2-year audit of antimicrobial use and the hours it took to do that. So this is about getting efficient, much more efficient usage of drug time. And ultimately to think of other smarts around influencing clinician decision-making, as well as the input that clinical pharmacists make, of which there are pharmacists there 7 days a week, 14 hours a day, but they're not there for every doctor and every patient. But it's actually how you can build these things in, and as we all know, medicines management is extremely complex. And the decision-making is based upon scripts in Mark and Louise's heads, which have been based upon years of experience. Then as new data comes out, new evidence comes out, but also the influence of both nurses and pharmacists and obviously, of course, patients. What we don't want to look at is a recipe book, cookery-based process, which has a drop-down box, which allows us to all prescribe beautifully a drug, and a dashboard that shows exactly how we're prescribing it. It's just in the wrong dose and the wrong drug for that patient with those diseases, with those comorbidities. This is extremely complex. For those who aren't in the world of medicine management, optimising medicines and prescribing is the most sophisticated and complex system you will have ever have got into. We are not looking for some kind of cookery book answer. This is extremely complex.
I was just wondering if you could give us a bit of an indication about who you might have found are the primary offenders for inappropriate prescribing. So is it the interns when they first start their term? Do they get better over the course of the 12 weeks? Is it the registrars?
It's actually a bit of the top and bottom. It's the top because the juniors look to us and say, what do I do here? And we just go, I just do that, because that's how we've always done it. And as I said, it's hard to get us to change our behaviour. But it's also at the bottom end, because a lot of these interns come with influence, they've been influenced by the previous terms that they have done. So they rotate through the hospital and do medicine, surgery, emergency and things like that in their very first year. And they, of course, are influenced by the seniors who've told them how to prescribe as well. So sometimes they do things automatically because it was right in that term to do it that way, and I'll bring that to the ED and I'll do those same practices here. So there's actually issues at both top and bottom. Yeah.
Hi. With the introduction of FirstNet across the state and how Metro North is taking time and waiting for everyone else to iron out the issues, how do you think the dashboards and do you know how medications are currently input into FirstNet, and with the dashboards with FirstNet, will that have some influence? And what you are asking people to do here is utilise that data and bring it. It's going to be on a screen within a department, but you're trying to find ways to communicate that out to all the clinicians, not necessarily just the department heads So do you know whether FirstNet is going, because it does have dashboards?
It's not. From what we understand at the moment, FirstNet is not a solution.
Yeah.
Within FirstNet, you can build in clinical decision support aids behind that to try and influence different things from there. But this is more about, at a macro level, we want to create behavioural change in this and this and this. We want clinicians to see the value of the care that they are prescribing, the equipment that they are using, the procedures that they are doing, the medications that they are accessing, the x-rays that they are ordering, the pathology that they are ordering, and then own the issue that we have a fixed bucket of money with which we need to continue to care for people with a rate of growth of 3 and 4%. So where can I save 5 or 10% in terms of influencing some change in people's ways to create those resources that I can then keep a sustainable healthcare service? This is the bit that clinicians aren't engaged. We talk about how do we change the cost of medicine, and yet the people at the coalface who are making the decisions don't even know what the cost of what we're currently doing is. We don't have any understanding. And as I said, it's only when you get to the senior level, the department heads levels, where you see reams and reams of pages of this is the stock that we've used over 12 months and this is the cost of it. Nobody has any idea. It's one patient, one-on-one, I prescribe 3 drugs. That's it. I don't see that. I don't see that that's cost the department X amount of money and that these other alternatives were available. Or if I had have given that as an oral, we got an email a couple of months ago now that I keep coming back to, which I smile. It's one drug. And the email said, if people don't have gut failure, if they've got no gastro sort of implications, this particular drug works equally well as a tablet as if we give it as an IV infusion. This was an email that came out. Now, I read it because of my interest in this subject, I've got to say. And then I walked around the floor and said to people as I'm watching them prescribe that drug intravenously, why are you giving it intravenously when you give it as a tablet? Oh, because we always do it that way. Do you know that, and then I investigate cost, do you know that it actually costs 4 times more to do it that way? And that's just the cost of the drug to get the staff time. We don't have any line of sight of these issues to be able to then say we want to be part of it. And we've got a very innovative, proactive department that is forever seeking to try and improve our care based around evidence-based care, but what can we do? And that's why things like even the cannulation study came out to try and see can we stop that. You know, we do things because it's habit, because it's culture, because it's the way we've done it, and we need someone to shake it up for us.
Two quick questions. The first one is there going to be a data set provided with all the indication and contraindications of the medicines?
We don't really want that.
No. And the second one, is there a path to commercialisation post-POC? Obviously, the budget's allocated, everyone will most likely put in above and beyond to deliver a really good result, but then how is their adaptation into the health system?
I suppose to answer that question really is the path to commercialisation is the funding that's provided for you to do the research and development. And then of course, if you're looking to go further into the health system, it would be in developing your solution, it would be applicable to Queensland Health and then have broader applicability to be able to use through other, I suppose, processes and services in Queensland Health. So to think along those lines would, I suppose, be the key thing to getting it into, further into the market if you're looking at doing it through Queensland Health. But alternatively, your product or service that you develop could be commercialised through other states, internationally. I'm sure this, well, as Louisa said, this problem exists in many other places as well. So it would be through there, but essentially through the SBIR program, the commercialisation path is because we provide that research and development funding.
And then, so beyond the POC, that it doesn't set you up to come onto a procurement panel for Metro North to actually...
Sorry, yes. To answer that, you don't have to go through another procurement process. So in going through the SBIR program, Metro North can then procure the solution directly from the solution provider. You don't have to go through another procurement process.
Fantastic. And will your ability to meet criteria of a Queensland tenderer with your insurance and liability, will that be accounted for in the application?
Yes, sorry, I'm just going to hand over to Therese, who knows a bit more details on the terms and conditions.
Yes, so Christine referenced the terms and conditions. It's probably best to review those in detail. In terms of eligibility at this stage, it's pretty broad. You just need to be in a position where you can form a contract with us at the time of feasibility starting. Any additional sort of considerations about insurance and things like that, we will require insurance. The details are in the terms. Any other sort of RTC procurement things prior to implementing and commercialising, that could be explored, for example, through the proof of concept stage. So the goal would be, at the end of the proof of concept stage, there would be a pathway for how you take your solution to market, both to Metro North and also wherever else you plan to commercialise it.
Just one clarification about the list of indications and contraindications, and I probably need to explain that a little bit more. It may be for one particular drug that we do have to focus on indications, that people are using it beyond that, but it might be for another drug, it might be that there might be other things that are needed to influence change from there. So, you know, as I said, about alternatives rather than just indications for one particular drug. So for some particular medications, it might be that, okay, yeah, let's try and get people to move towards this, or the new guidelines suggest that we use it at this dose and not that dose. But it's not just that, if that makes sense. Was that a second question? Sorry. Apologies. I heard the last bit, I didn't know your question.
Yeah, the reason for asking for that was, how do you then create an output where you've got comparators listed at the different prices if you're not taking into account where's that data coming from? Is that just going to provide that if you're getting prescribed A, these are the only other 5 comparators available and these are their costs?
So I don't know whether it's going to be at the point of prescribing, you know, at that individual point, or if it's something that's higher up in terms of people's psyche. To produce something that's there, because as Ian's mentioned, we don't have electronic prescribing at the moment, so there's not something that we are handwriting things onto paper charts and things like that. So it's got to be something, people's education, recall, awareness, that there is something that is there. So it may be some sort of rolling campaign of information that is going on at any one time for different costs and things. It may be, you know, our target usage for this particular drug is here, and here's where we've tracked over the last 6 months, and now we've done this, or now we've done that, or, you know, it may not just be about something. There'll be parts of clinical information that may need to be in there, but there'll be other new information that we've never had access to before as well.
You make a good point. I mean, coming back to the fact of being multifactorial, one of the nicest examples recently in the hospital of choosing wisely was in theatres, where they looked at the use of one of the standard local anaesthetics with and without adrenaline. And one of them is like $8, and the other one's about $1.40. And actually, physically having that in the anaesthetic rooms, near the trolleys, in the place where people were selecting it, because anaesthetics is very similar. It's a 24-hour day, huge amount of visiting physicians, very consultant-led, anaesthetic techs also involved. But in fact, with some communication, physical actual feedback on usage versus, you know, and the time when you specifically would want to use one drug versus the other, showed a significant reduction in use of the drug. And often, as exactly as we said, the feedback from the users was, I had no idea. Nobody ever told me. I'd always done it in my private rooms. I just have this in the trolley, so I go to grab it. But in fact, when I went to grab it, it was a case of, do you need to use this or should you use that? And that was a dramatic impact. But I think it's also back to the fact that, you know, antimicrobial resistance and antimicrobial stewardship, which you're all familiar with, is something which we have had big gains on, but it's a multifactorial sort of approach at multiple different levels. And there's long gains and short gains. There's forcing functions which are you physically can't get the drug, or you've got to get the ID consultant on the phone to get it, or we don't put meropenem on the floor or in the picture so you can get it out. Versus the fact that, and you use traffic lights of drugs, so therefore you have different sort of levels of decision support around using them. But at the same time, so there's the forcing function, but the other best way is to actually influence people's decision making so it becomes part of the way we do business. And the point around oral absorption of metronidazole versus IV, or the fact around using doxycycline versus IV azithromycin for somebody who thinks got an atypical organism with a community-acquired pneumonia, that kind of feedback is something which, it's often led to the way people have done it before. And hierarchies are a huge influence. When we've looked at influence of junior doctor prescribing, what the boss does and what they've seen before is the biggest influence all the time. And also, as Louise said, the consultants are stable. So although there's a massive raft of juniors, influencing the senior people is a very important way of changing behaviour. But at the same time, having decision support, having the right drugs available, making these do the right thing, and having pharmacists help optimise drug therapy at a proactive time of decision making are all multifactorial approaches to this.
Can I just give a bit of perspective in terms of the throughput, just as well in case anyone was looking at the behavioural management perspective? So there's the consultants are stable, and there's a core group of pharmacists who are stable, and the nurses are fairly stable, give or take. The registrars will rotate through on a 6-month basis on average, some will stay a bit longer, but usually they're a 6-month term. And the interns, the junior doctors, they rotate on a 10-week. Some of them are 5. So realistically, you've got to get them when they're fresh, get that any change in fairly quickly, and then get that sustained, but also taken off, bearing in mind you won't necessarily see them week to week or day to day because of shifts. That's just the sort of chronological issue that we have with that.
Just thinking about this in terms of using data and technology to support that behavioural change with clinicians, would the key data set to support that, is that in Pyxis, or are there some other data sets as well that might be useful with that behaviour change?
For this one, yes, it will be the information we can get from Pyxis. We've got historical data pre-existing though in terms of the previous 12 months of or years and years of stock utilisation that we can look at about how things were before it all happened and where it's going from there. But yes, in terms of, for this particular focus on medications, yes. If we talk about radiology and pathology down the track, there'll be different databases from there, but it is something that can capture that information, give it to us in a format that's useful, relevant and helpful.
So the iPharmacy system, which is our statewide overall distribution system, procurement system, will give us historical data of what drugs have been issued to the emergency departments, but obviously it's not tracked to the individual patient. We now have a dispensing robot as well at the Royal Brisbane, not at the other hospitals, but that'll actually, for the non-Pyxis drugs, because they'll actually cover about 80% of drugs out of Pyxis, 20% which are not the first line acute drugs which we dispense subsequent for people with often chronic ongoing therapy, that will actually be trackable to individual dispensing through iPharmacy system, or which obviously comes also in the future out of our robot. So that data is also part of sort of available data.
Thanks. Just to follow up on that, is there localised healthcare costs specific to your ED that would factor into your decision making, that where we can get data from that, or is that not so?
Yeah, no, in terms of the cost of the pharmaceuticals, there is a cost, but that's more at a probably state-based level, in terms of the cost per drug.
It's drilled down per ward, per unit, but as I said, at the moment we don't have the ability, the analytics to be able to track it to individual patients, because the interest of the ward is issued and the non-interest drugs are dispensed. But the gap that we're filling with the Pyxis is we'll know where the drugs are on interest, which patient they are actually going to, and at what time they are being given to those patients.
So we know about the cost of the individual medications. The hard thing is the cost of time for clinicians, which is something to factor into any cost of because there's one thing which is just the tablet or the drug. There's the next thing about that whole process of care in and around that. There's some metrics that we've tried to drill down in different situations to try and work out what the cost. We can tell you how much it costs for our wages, in terms of things like that. And we can do some, time and motion studies to look at how long it takes. I think they've already been done for a nurse to pull up an IV infusion, for example, and dispense that. So there's that sort of stuff on top of it that we can give a generic cost to. This is the amount of cost that it takes for personnel to dispense a tablet versus IV solutions as well. There's that sort of stuff we can give you too.
we've had some protein attempts to feed this data back to our users, if you like, our end users, by establishing a list of the 10 most expensive commitments we've had in pharmacy in terms of our prescribing, and talking about modifying those in meetings, and that has been relatively ineffective. But we certainly have established that for our local environment, for our emergency department, that we spend this much money over this time period on prescribing for tetanus immunisation and giving normal saline bags for gastroenteritis or whatever. And that hasn't been especially effective, but it, in some ways, has formed, in a protein way, what we're doing now.
Hi, just a logistical question, I guess, about the submission. Is there a particular format that you want to see? I know there's a spreadsheet that needs to be completed, or a budget sort of file that looked like it was part of the inclusion, but I've seen some Queensland government tenders that are fill out this Word document with whatever sections.
Oh, I'll hand over to Reece, but no, under the SBIR, we've kept the application process simplified. Reece has more details on how that actual process works.
So it's just online through the Smarty Grants platform, accessible from the Advance Queensland website. It's a few brief questions for each of the 5 evaluation criteria, as well as some basic information about who you are, who your organisation is, contact details, things like that. And as you pointed out, also a spreadsheet outlining your sort of budget, so which will set out activities that you're proposing to undertake through the feasibility or proof of concept stage, as well as how much funding you're seeking for each of those activities, and how long each of those activities how long you expect each of those activities to take. So as Christine said, we've tried to keep the application as simple and streamlined as possible, but yeah, that's the format.
And I think it's just worth noting that if you click on apply now, you're not then having to submit anything there and then, but you'll see all the questions and you can sort of take your time to come up with the answers and propose your solution that way. So I'd encourage you to click on apply now, have a look at those 5 assessment criteria, read the T&Cs, and go from there really.
This is a very minor question. I've submitted to one of the previous SBIR challenges. It's all plain text in web form in the submissions, and I wrote some nice bullet pointed things to get in the word limit, and then the web form threw away all my white space and carriage return and line feeds, and so it looked like a horrible mess. Is that do we need to write paragraph format only, or will you be able to do some spacing and formatting?
Was that an application for our first round?
I think it might have been about 3 years ago.
So we have a new application system now, which is better. You still don't have rich text editing.
No, not rich text.
But if you
white space,
if you double space whenever you're trying to put in a new list item or things like that,
carriage returns,
it will carry that through.
Okay, I think we're getting close to wrapping up. Obviously, if we can't take all questions today, there's the email address to submit, but we'll take a few more.
I'm just wondering, when you've looked at the solution, have you identified any KPIs or metrics that's going to be the successful outcome? When I'm looking at this, I'm thinking you've identified cost, but then does that also lead to clinical care? And then would you expect this solution to assist you identifying those KPIs or measuring them?
So in terms of clinical care, of course, we are not going to be trying to suggest people do anything that is less efficacious, less safe, less helpful to the patients. But what we do know as clinicians is that there's alternatives out there. So we're not going to be trying to adversely affect patient care. We will be looking not only at cost, but in terms of sustainability of change, whether or not we can create, to create change in the ED is incredibly hard. So if we can create some change, that's one measure of success. By what degree? It will depend, depending on which particular medication that may be targeted or looked at, because as I said, I think there's variability in terms of appropriateness. For some drugs, a 5% change in the utilisation will be valuable. For others, we will pitch for harder. Or we will hope for harder, but it's going to be also, in terms of an outcome that we want to see sustainability. And that might be working out how frequently we need to message people because we have this huge turnover of juniors and things like that. There might be part of that as well.
Hi, would the prescribers have time to actually enter a drug and say, okay, there's another alternative solution out there, or would they have the time during the ED because it's very intense and
if you come with a solution like that, then maybe we've got to find a way of doing doing things differently. This is part of our change, and so I wouldn't negate that as something that we wouldn't need to say we can't have that as an alternative.
If you enter a drug and it gives you a list of alternatives, something simple as that.
No, absolutely, we wouldn't say no to that. There are, as I said, there are some support tools, but I don't think I know of anything like that just at the moment. We've looked at different options, of course.
Sure. Thanks. I know there's a tag along sessions after the feasibility study or something. Is there a possibility to tag along before the feasibility study, before submitting the stuff?
Tag along. Yeah, so in terms of coming and accessing us and seeing how it all goes.
Yeah.
Can I do something like that?
That's a difficult one to answer. Firstly, SBIR is a procurement process, so it is about providing equal information to all applicants. So to do one-on-ones would not be possible. So you can submit questions to SBIR to the inbox, and we can then seek the answers through Met North and provide those answers. If it's not information that is publicly available, we then have to provide it publicly to everyone and all applicants.
Just a question for you. Could I seek a time where I could arrange with Metro North for whoever's interested and say, I'm creating this opportunity for half an hour, I'll walk you through the department, I'll show you what it looks like, I'll show you how we think, I'll show you how crazy it can be, hopefully I'll bring you on a non-crazy time. Could I do that?
It's coming exactly for everyone.
Yep.
Yes, and all applicants are advised that's available.
I think we work in such a bizarre place. I mean, this for me, I'm a fish out of water. You can see this isn't me. But I think where we work is so different for people that if I can talk to Metro North and create that sort of opportunity to have just a handful of us and then open for everybody to come through, I'll find a time that's least crazy business, and I'll walk you through the department quickly, and then we can have a conversation about some of the other bits behind if
Okay, then probably to organise that, if anyone is interested in that opportunity, probably just email the SBIR inbox, and we'll go from there in terms of trying to figure out the best way to do that.
Okay, under SBIR, I suppose really the aim of it is to support Queensland startups, Queensland small businesses. But the other key thing of SBIR is having a solution that addresses the challenge. So that's really the key criteria. SBIR is compliant or does meet the Queensland procurement policy. So under that policy, there is a weighting for the benefits for Queensland as well as part of that. Any more questions to Louise's team while they're here?
As a clinician, can I say thank you? Just even the fact that there's anybody in the room at the moment floors me. So I really hope that we can find something that will be a solution for this. As I said, we as clinicians, we want to be part of a sustainable healthcare system. We're losing opportunities now. We don't know how to fix it. So your smarts and your clevers and all the skills that you bring, I hope is going to provide us with an opportunity for us to go somewhere else. And we're really excited to be part of this, and thank you for coming.
Yes, just to wind up, thank you to Louise and her team for presenting and for providing the opportunity for you to ask questions to get to know this challenge further. As we mentioned earlier, there's an opportunity if you do want to talk amongst yourselves. There might be some of you that have part of a solution. You can network amongst yourselves. So please, there's refreshments here, so you can stay for another half hour, have a chat as well. Thank you.